intralipid infusion is as such a very, very, very big thing, right? When a patient is undergoing an IVF cycle or a patient has had previous abortions, very, very commonly we see the use of intralipids in clinical practice by fertility physicians where we do not know if it is actually indicated or not indicated to the patient. Though it is something which is available as a not so expensive product, we must be very, very judicious when we use intralipids over a patient because we do not know how using intralipids is actually benefiting the continuation of a pregnancy. That is point number one. And second, many a times it can be exploitation of the patient's anxiety. See, if you have had 2 or 3 abortions, 2 or 3 IVF cycles failed, most of the patients are going to be in a mindset that they are willing to do absolutely anything the doctor is going to tell them with a blind trust on the fertility physician. And that is a very responsible choice which we as fertility physicians should make before we prescribe an infusion of an intralipid to a patient. There is no debate that in some cases intralipid infusions benefit the patient. So let's not get into that. Through this video, we will try and help everybody understand how it works. Does it actually work or not? What are the prerequisites for us to do this? And what should be our counseling points to the patient? So what is an intralipid? Basically, an intralipid, as we are all aware, it is an infusion, right? Now, this infusion is administered through the IV line. It is standardly available as 250 ml infusion bottles across the country. It is white in color to be protected from sunlight, not very expensive. Also can be used as parenteral nutrition. Okay, so parenteral nutrition is something which we give in the ICUs to patients who are very, very cachexic, have lost a lot of protein mass, muscle mass, and all these types of things. So it is the same infusion which is given to the patient. How does it help the patient? So it is believed that it goes and acts on the uterine natural killer cells. These are special types of natural killer cells. We have described them in our previous master classes, which are present in the endometrium, in the uterus, and it goes and binds to the PPAR receptor. Okay. So this is basically a peroxisome associated receptor which is present on the uterine natural killer cells, and thereby it sensitizes the uterine natural killer cells to make sure that an incoming embryo is absorbed very nicely, right? This is the mechanism of action, or one of the mechanism of actions which we know, correct? Now, in what situations is this going to be greatly benefit to the patient? Remember, any immunotherapy will work on a normal pelvis. That means the patient should not have fibroids, no endometriosis, no adenomyosis, every other factor to be ruled out. No other detectable autoimmune condition. That means no rheumatoid arthritis, no SLE, no APLA, no anticardiolipin, protein C, protein S. Nothing has to be present. It has to be a normal pelvis. Simultaneously, it has to be a euploid embryo. That means the embryo should be genetically, chromosomally normal. And this is useful if it is a self cycle. That means if it is a self egg and a self sperm pregnancy. Many a times what happens in a country like India is somebody has had 2-3 abortions. They go to an IVF facility. The IVF facility will tell them, it looks that your eggs are not good. Let's go ahead and do treatment with donor sperms or donor eggs, whatever is deemed necessary in that case. That is not the case where you need to give them intralipids. All right. So keep that in mind. These are your prerequisites. Let's assume you have done any of this and the standard immune therapies have not worked. That means, for example, the standard immune therapy would be to give steroids to the patient, would be to give HCQS if indicated, would be to give ecosprin to the patient, would be to give low molecular weight heparin to the patient. And if all of this have failed in a previous attempt, you may consider to give intralipid infusion. The word is you may consider, right? How much it benefits a particular case, we don't know, right? But in certain cases, it may be statistically significant where all of this has failed, right? How do we give the infusion? So there are various regimes which are available. Usually people would start giving the infusion approximately 20 days prior to starting the embryo transfer. That means in the previous cycle. Just like how IVIG is given. It is repeated either weekly or 2 weekly. So either you give it every week or you give it bi-weekly. All right, as an infusion to the patient. And there is no standardization to this. Correct? Some people are happy with a weekly regime. Some people are happy with a bi-weekly regime. You need to give it basically till approximately 10 to 12 weeks of gestation. That means once the NT scan is done and it is normal. Now, is there any role of giving an intralipid infusion beyond that? The answer is we don't know. Do we need to give it only till cardiac activity is present and will it help? We don't know. Right? So there are many things to this science which we don't know, but what we know is that it should be a normal pelvis, euploid embryo, and self cycle. Now, after having learned all these things about a standard intralipid infusion, okay, please remember majority of the times in a country like India or anywhere else, intralipid infusions are predominantly given with other immunomodulators. That means you may give HCQS with intralipids, you may give steroids with intralipids, but majority of the people do not rely on intralipid alone. And that is a very important point. So if you are a patient who has been prescribed intralipids, please have a background check of all these things done by your fertility consultant. You can have an open discussion with them. And then if they guide you and they tell you that it is going to be beneficial in your case, that is when you need to choose to take it. Otherwise, remember, it is an oil-based emulsion. So what typically happens is there could be some reactions in some patients. Otherwise, it is given through a standard IV line in an hospital setting. You can't take it at home. So you are going to be admitted to the hospital when you take this drug, right? Having learned all of this, what is important to understand is that immunology in reproduction is a very, very developing science. No one knows what works for which patient and how much is required for a particular patient. No one knows this. There is no standardization to a lot of these therapies because a lot of these therapies currently may or may not have a proven basis behind it. As a result of this, the best you can do is to meet a reproductive immunology specialist because for every 100 patients whom we see, for 70 patients, we may not suggest any form of therapy, or we may suggest a better form of therapy after a thorough evaluation. Only once your evaluation is complete, you need to jump into these therapies because remember, if these therapies were so good that everybody would be using it rampantly. The thing is, every therapy may or may not work on a particular patient, and we need to be crystal clear about this message before we prescribe these drugs to any of our patients. More questions you can post in the comments. We shall be happy to answer.